So, welcome to I-CBT Fridays. We're glad to be back in the fall doing presentations and sometimes doing consultations as well. Our mission for I-CBT Fridays is to expand awareness and to educate clinicians and provide an opportunity for consultation and collaboration on anything I-CBT, the inference-based cognitive behavioral therapy. I am Margaret McVale. I'm one of the facilitators, and I'll be facilitating today. I do this along with Mary Hosbrow and Sylvie Levine. Our job is to plan and facilitate content for these meetings, so you can feel free to reach out to any of us if you have ideas for future presentations. Today's video will be recorded and posted online. Today's video is going to be on Imaginal Absorption by Carl Robbins, and I'll let him introduce himself and explain if he wants to have questions during the presentation or if you need to hold them, but you're always free to post your questions in the chat, and we'll be keeping an eye on those. So I'm going to let Carl introduce himself.
Hi, I'm Carl Robbins. I'm an LCPC, and I've been treating OCD and anxiety disorders for almost 40 years. I'm a senior clinician at the Anxiety and Stress Disorders Institute of Maryland, which is directed by Sally Winston and Sarah Crawley and Mike Hetty. And I'm also on the faculty of the University of Maryland School of Medicine, where I teach third-year residents. Can I share my screen? Get started here.
Well, if you can. If you not, I'll give you permission.
Yeah, okay. Let's see. All right. All right, can you see that slide? Okay. All right, what I'd like to do is to start off with a word association, a single word association, right? And the word that I want you to associate to is dissociation. What's just in the chat, type in whatever comes to mind when you hear the word dissociation. And let me check out the chat and see what people. Yeah. A few, a little bit longer. Good. Okay. So, yeah. A lot of associations to trauma, to dissociative disorders, and also it's interesting. There's some words here about escape and avoidance. That it's a kind of reaction to stress. It's a maladaptive reaction to stress or distress. Okay, all right, good. Okay, so see here. I am here to talk about how useful it is to think about dissociation not just being within the context of trauma, right? And there's a growing body of research about the connection between dissociation and psychopathology, particularly in obsessive compulsive disorder and obsessive compulsive symptoms. Actually, you'll see this abbreviation here where I'm pointing to. This is just OCD and OC symptoms, all right? And it's not intuitive for most people, all right, to sort of think about dissociation out of the context of trauma, because generally we tend to belong to one of two fields, right? Either the trauma dissociation field or the OCD field. Now, there are noticeable exceptions, including Bronwyn Schroer, who had that fabulous presentation last week. I highly recommend, and be great to have a conversation. I don't know if Bronwyn is here today, but it'd be great to have a conversation with her about the role of dissociation in OCD versus trauma, and how you make that distinction, if it's a useful distinction, et cetera. Okay, so that's so I'm just going to be on my soapbox and say I really encourage you to start to consider dissociation in the context of, for example, there was a seminal paper by an Israeli researcher whose work I'm going to focus on today, where she talks about the role of dissociation in depression, in panic disorder, and in OCD, right? And I've come to really sort of appreciate this very much in my work with patients with panic disorder, for example. That we obviously depersonalization, derealization is often a consequence of panic, but there's also a reciprocal relationship where imaginal absorption also drives panic. And that's what I'm trying to, that's one of my goals today, is to sort of help you consider the fact that there is an interaction between OCD and dissociation, between inferential confusion and dissociation. And that it's not just the consequence of distress. Right. So little bait and switch. I actually built this into the title of my talk. Dissociation ain't just about trauma, imaginal absorption, and OCD. Right. And here's a statement that sort of, and actually this has to do with my own sort of personal revelation that made such a big difference in terms of my own lived experience with OCD, is that being in the OCD bubble is a dissociative state. So just a little bit about my own personal history. I'm 71 years old, and I was born in the Jurassic period of OCD treatment. And actually, in the early 60s, OCD found me, and that was before the beginning of the modern era of OCD treatment with Victor Meyer and his pioneering work with ERP at Sussex Hospital in England. So it's interesting because my lifetime has been sort of witnessing, what's happened in the field. And in the early 60s, going into the 70s, it was, at that time, OCD was seen as extremely rare and not treatable. So fortunately, we've come a long way. In 1984, I began my career as a therapist, and with Sally Winston as my mentor. And then it was more than 30 years later that I discovered I-CBT. So I want to talk about dissociation, particularly imaginal absorption, getting lost in my imagination. And there were two seminal moments that turned out to be transformational for me. In 1977, I was in a Gestalt workshop, and I was droning on and on about worrying about what people were thinking of me as it was my turn to do work in the Gestalt group. And the Gestalt therapist very sort of matter-of-factly said to me, "Watch the stories that you build." And it was a profound moment of sort of recognizing the extent to which, in this case, on an interpersonal level, my own narcissism, my own social concerns, was largely based on being immersed in these stories I was telling myself. And then when I discovered I-CBT in 2018, I really, I've talked to Fred about this a couple of times. It was really module 7 that did it for me. And the whole notion of the bridge between the senses and the imagination, and just this sort of fundamental recognition of that I'm just making this shit up. And I like to refer to it as my Marcy isn't real moment. If you know The Beautiful Mind, where John, I'm blocking his name, the physicist, sort of recognized that his delusions and his hallucinations were all a product of his own mind, and it was you know in the old days people used to go to Est and they talked about getting it. It was that kind of experience. Oh my God, this is just all in my imagination, and which I get lost in it. And the idea is to recognize it and come back out of the bubble, come back out of the imagination, come out of the dissociated state. And I had a conversation with Fred earlier this week, and he talked about this idea that there is that with I-CBT, we see these realizations, this sort of fundamental sort of recognition of getting it, of sort of understanding it. And sort of like once you see it, either as a clinician and or as a sufferer, it's hard to unsee it. Let me just, I'm going to get back on my soapbox for a second. I want to talk about something that I call iatrogenic passivity. All right, which is I think that very often with the sort of traditional ERP intrusive thought model, and even the introduction of sort of bad act, is that we can actually promote a kind of unfortunate passivity or even helplessness in our clients. And to sort of recognize that there's a choice about whether or not one goes into the OCD bubble, right? That these aren't just sort of, random intrusive thoughts that pummel you, and you just have to learn how to not engage with them or diffuse from them or tolerate them or whatever. And so it is neither experiential avoidance nor thought suppression to recognize and stop yourself from going into the OCD bubble, right? That is not pathological control. You don't have to watch your thoughts, allow your intrusive thoughts, tolerate distress, nor accept uncertainty. And I think that, I-CBT, metacognitive therapy, particularly attention training, and Greenberg's work have sort of all converged recently for many of us to sort of recognize that we have choices, and that rumination isn't necessary, going into the OCD bubble is not necessary, and there is such a restoration of a sense of agency. I think that that's one of the things that many of us notice about I-CBT. It's such a tremendous sense of agency that patients get. Okay, I'm going to some of you have seen me talk before, have seen me do these exercises, but this is one of the ways in which I introduce to clients about the experience of going into the bubble, or going into worry or an obsessional story. So what I'd like you to do is I'd like to pick a worry or an obsessional story. If it happened to have OCD, pick one of your obsessional stories, or pick a worry. And when I say go, what I'd like you to do is I'd like you to go into the bubble on purpose. I want you to sort of immerse yourself into the story. Okay, ready, go. Really allow yourself to be absorbed. Make it as vivid as possible, both with words and images. The more detailed, the better. Okay, now come back. Everybody back? Okay. Now, it's interesting when I do this, is that notice intuitively, you know what it means to come back. Notice how easy it is. So how'd you come back? Anybody? How did you, when I invited you to come back, how'd you come back? Anybody want to speak up or say something, put it in the chat? Or
I look back at the screen.
Yeah. You came back to me, right? You re-engaged with me, right? Okay, exactly. And because in a fundamental sense, right? I'm real, right? I mean, I'm here. You can see me, right? Okay. So what I want you to do is I want you to go back in the bubble and notice that there's something that you do automatically, behaviorally. Okay, I want you to go, ready, go back into the bubble. There it is. What'd you do? Margaret, you wanna
I look away. Yeah, I look down from the screen. I look away so I can focus inward.
Yeah. You looked away. You withdrew your attention from sensory experience, in this case, the visual sense, right? In order to be able to sort of leave the here and now, leave sensory experience, leave reality, to be able to sort of go up into your imagination, right? And there is the direct experience of the difference between connected to reality through the senses versus disconnected from the senses, disconnected from reality, and up into imagination. And it's hard to do both. I will demonstrate this to you. So go ahead and stare at my nose. Now go up into your imagination. It's a lot harder, isn't it? Right? It's a lot harder that when your attention is anchored in the here and now, right? It's much harder to get lost in your imagination, right? And it's not that my nose has some kind of fundamental anti-obsessional effects, right? It has to do with basically, attention and choice. So if we come back to module 10, I'm sorry, module 7, right? The instruction is to pause on the bridge when you feel yourself going into the bubble and look back for a moment in the world of where the senses came from. All right. And out there in the world of the senses, the doubt was irrelevant. Okay. So the interesting question is imaginal absorption, which is a form of dissociation, is that simply the consequence of inferential confusion? Or isn't there an interaction? Is there a reciprocal relationship between inferential confusion and imaginal absorption, which is a form of dissociation? Right. Okay. Now, I'm gonna take you through another exercise. I attended a training on using imagery to enhance ERP. And here's an imaginal exposure exercise, and I want you to notice how this works. All right. Okay. So put yourself in the place of a client who has contamination fears. All right. And here's a head of lettuce. And as you look at this head of lettuce, I want you to think about the fact that probably, this is, since this isn't since you bought it at the supermarket, this has probably been through machinery. And and that in the course of being exposed to the machinery, this lettuce has probably come in contact with other vegetables, or for that matter, has probably come in contact with other food products, other farm products, right? Which is why you hear about bacteria that isn't necessarily associated with lettuce, right? That ends up cross-contaminating and inducing foodborne illness, for example, E. coli. So this cross-contamination happens because of this encounter of this head of lettuce with other contaminated food products, perhaps even related to a meat packing business. Okay, so you can understand why the E. coli very much probably has bacteria on it, right? So this was the exercise, right? There are a couple of things that sort of strike me about it. First of all, it is using many of the tricks of inferential confusion to, in a hypnotic way, to create a dissociated state where you encounter, where it seems as if the lettuce is actually contaminated. All right, it's the imaginal script is a form of hypnosis. It induces a kind of trance, a kind of dissociation. All right. Now, in fact, I will tell you that you know that the presenter actually apologized for creating an immersive state in the participants for such a disgust-inducing script before lunch, so that the goal was to actually create immersion, right? And so, if this makes sense if you see OCD as a phobia, and what you want to do is immerse yourself in the feared outcome, in the core fear or whatever. But from an I-CBT, from an inference-based approach, what you're actually doing is using the reasoning errors of inferential confusion to encourage the client to go into a dissociative OCD bubble, and somehow that's therapeutic. So, I, as you can probably tell, I am not a big fan of imaginal exposure, because the more I learn about I-CBT, the more it just absolutely makes no sense, particularly since what studies show is that many patients are actually prone to imaginal absorption, right? There's actually some evidence that it's an innate characteristic or trait, right? And so, at the very least, if you're going to do imaginal exposure, it makes sense to sort of consider, that you may be actually reinforcing or even flooding people who are more prone to getting lost in their imagination. End of that soapbox. No more soapboxes. So there's there is this Israeli psychologist, Nurit Sofer Dudek, and I really encourage you to take a look at her work. She's brilliant, and she's been publishing quite a bit over the past 10 years on the connection between dissociative states, dissociative experiences, and psychopathology. And there's a fascinating article that actually Fred posted in our Facebook group, talking about OCD and dissociative experiences. Okay. So when you look at dissociation in DSM-5, it immediately sort of connects it with dissociative disorders, and we associate with trauma, and there's a sort of fundamental sort of focus and bias that I think many of us get diagnostically. All right. Let's drill down into this. One of the problems when you start talking about the dissociation is that it's not exactly clear what we're talking about. It means different things to different people. There's sort of like this vague sense that it means shutting down or checking out or whatever. If we look at the dissociative experiences scale, which is the standard for measuring a dissociation, there are 3 subscales: amnesia, depersonalization and derealization, and what's called absorption and imaginative involvement, right? Sometimes abbreviated as AII, right? And and depersonalization, derealization are sensations of detachment from oneself or one's environment, and AII is a tendency for experience in immersive attention towards either an internal or external stimulus accompanied by obliviousness to the surroundings, right? This sort of narrowing attention and this sort of getting lost in either internal or external stimulus. All right. Just to give you an idea, here are some of the questions on the DES, on the dissociative experiences scale, that measure absorption, right? And so for example, 15, some people have the experience of not being sure whether things they remember happening really did happen or whether they just dreamed them, right? And I'm going to have more to say about this later. It's almost kind of like this sort of pseudo amnesia. And some people find that they're watching television or a movie and become so absorbed in the story that they're unaware of other events happening, right? Some people find that they become so involved in the fantasy or daydream, it feels as though it was really happening to them. This is this lived-in experience that comes with absorption, right? That we see in OCD all the time. All right. So if you look at the ICQ, there are a number of questions that ask about this tendency, I would say even trait, to get easily absorbed in one's imagination, in remote possibilities. Right? So here, like number 9, I sometimes forget who or where I am when I get absorbed into certain ideas or stories. And here you can see, in a way, this sort of combination of sort of depersonalization and imaginal absorption, and that this difficulty with the sort of sense of self when one is caught up in the OCD bubble, or right. And then other questions that sort of really get at this idea that it feels so real when you are immersed in your imagination, when you're immersed in the bubble, right? And let me move on here. Again, this idea that there's that dissociative experiences, particularly absorption and imaginal involvement is a transdiagnostic construct related to a number of psychiatric disorders that cannot be explained by trauma. In fact, there are studies that show, while there's a strong link between OCD and AII, as well as the personalization and realization, they are not correlated with trauma. It is what we see in OCD is not trauma-based, right? So here's an interesting finding, right? Higher baseline for AII, imaginal absorption, absorption and imaginal involvement predicts for a poorer outcome in treatment. So, this might be a useful assessment. And I wonder if, for example, these are clients for whom I-CBT might be the preferred intervention. Okay, so let me focus on this third point, right? Imaginal absorption is a common experience, right? And it can be either be internally focused or externally focused. For example, when we are watching a movie or reading a book, right? And but another place that most of us experience imaginal absorption, a kind of a dissociated state, sort of being lost in our mind, right? Away somewhere, is in highway hypnosis. How many of us have had the experience that we are driving along and we realize that we haven't noticed consciously, we haven't noticed a single thing that we passed in the car because our minds have been elsewhere. Our attention has been elsewhere, And so one of the things that I've been sort of thinking about is that hit and run concerns often take place, or at least begin in that context, where a patient has been off somewhere else, right? And then they hit a bump, and then the doubt starts, and what might consider the possibility that that's not just random, that happens to hook people because there's a sense of, oh my, I really haven't been paying attention. I really haven't been here. I really have been lost. Maybe I did lose something, miss something. Maybe I didn't notice that I hit somebody. And this is where the suggestion is that there may be this reciprocal relationship between being lost in your imagination and not being able to trust your senses or yourself or your memory, is that it can work back, is that they can influence each other. And by the way, not necessarily just in the context of hit and run OCD. So here's some interesting EEG findings that people that are healthy people that are high in AII actually show lower EEG coherence, particularly decreased coherence in the left hemisphere. And the idea is that there may be this sort of fundamental neurophysiological proneness to become absorbed in the imagination, both in healthy individuals and in people with psychiatric disorder. Right. Oh, here's an interesting point that Dr. Sofram Dudek makes. All right. That attentional deficits and mind wandering cannot account for the association between absorption and obsessive compulsive symptoms. And so future research should explore whether reports of comorbidity between ADHD and obsessive compulsive symptoms may be inflated due to the misdiagnosis of absorption tendencies as ADHD. So when people sort of talk about sort of they're, you know, not being able to sort of stay focused and their mind wandering. Is that ADHD, or is this a this proneness towards absorption, right? Which are not the same thing. You may have heard of maladaptive daydreaming, which is this newly recognized, highly impairing condition that has high comorbidity with OCD, and these are patients that actually become addicted to going up into fantasy with that involve stories rather than sort of scary stories. They're quite pleasurable stories, normally where there's this idealized self. I have a patient who with a long history of maladaptive daydreaming, who can spend the entire day lost in a bubble. And he also has symptoms of OCD, particularly not just right OCD and OCPD, but he clearly has this maladaptive daydreaming, and it can be actually a disabling condition, right? And one of the observations is that these patients that are capable, and I will say capable of maladaptive daydreaming, it's something that most of us cannot do. Most of us cannot go up into our imagination, stay there for hours. It's a kind of a skill. This guy actually demonstrated to me once, and it was stunning about, you know, this capacity to sort of leave the present and live in this imaginative world that, as it turns out, was much more satisfying than his dreary life. And it can be a very, very difficult problem to break. But again, there's comorbidity here with OCD. Here's another interesting finding, not necessarily related to dissociation, but all right, which is that that excessive rumination over a period of months in patients with depression, anxiety, but not PTSD, all right, led to increased experiences of depersonalization and derealization. Right. So here again, this is this sort of relationship, this sort of reciprocal relationship between dissociative experiences and OCD symptoms, and other symptoms of in this case inwardly directed attention and rumination. So there is, in the I-CBT manual, there is a lot of mention of the term absorption. All right, and you know, there's you know, in my conversations with Fred, what he's shown, and I don't know if Fred is here, maybe he can jump in, you know, during the question and answer time, is that what his studies have shown is that versus virtually all of the sort of the experiences of absorption, dissociation, can be explained as a consequence of inferential confusion. I don't, you know, in the factor analysis. And so the question is that if you target the inferential confusion cognitively, is that sufficient for all of our patients to keep them out of this tendency to get lost in their imagination? Or are there other interventions that we might add that can supplement the cognitive work that we do in terms of recognizing and working with the tricks and cheats of inferential confusion? All right, So actually, there's in the manual, there's something, recent evidence appears to suggest that there's a tendency towards absorption, imaginative immersion that may be an important element in producing symptoms of OCD. So there's even sort of speculation here by Kieran and Fred that there may be this reciprocal relationship. And again, what's really important, and I think an important part of the psychoeducational experience is that absorption creates a reality value. It is that lived-in quality. It's that immersive quality that makes the story sort of feel so real, and that it is a lived-in experience that arrives with a considerable amount of arousal and emotion, and so let me jump ahead here. So let me get back to Sofer Dudek's work. All right. Although most OCD researchers see dissociative episodes as the effect of obsessive compulsive disorder symptoms and processes, there's a current formulation suggests that there may actually be a cause as well. Right. And so AII may contribute to obsessive compulsive symptoms as in addition to the cognitive risk factors. So Sofer Dudek talks about 5 different possible mechanisms at work here, right? And the first is this idea that that this inwardly focused attention, as well as these thinking errors, although she doesn't say it explicitly, but from an I-CBT point of view, the inferential confusion, all right, leads to this immersion in the bubble and this hyper-focused attention in remote possibilities in the story, right? On the other hand, another possible mechanism is that these getting lost in these vivid imaginal percepts, all right, in turn creates this sense of when one returns from the bubble, there's this sort of loss of a sense of she talks about a sense of agency, a sense that there's like sort of a disconnection between the self and one's agency, one's ability to control one's behavior, a sense of being out of control, right? And that in turn ultimately resulting in a distrust of the senses and inferential confusion. So here's an example that I certainly see, and I have one patient who is incredibly stuck on this, right? Which is that absorption produces a kind of emotional reasoning on steroids, right? Which is that I think, which is that this patient will say, right, it feels so real. I feel so anxious. I physiologically, I feel panicky. This can't just be my imagination, right? Right? It can't just be that imagining this stuff can create so much distress. I'll give credit to Stephanie Woodrow for this, that this idea that distress means that your thoughts are real and important and relevant is a certain kind of reverse reference or inverse reference, right? That we see in other reasoning errors. I mean, so that's one way of getting at it. But I think that there's a lot of psychoeducation to sort of help people, and through experiences. I know that there's some wonderful exercises that Bronwyn and Katie and Teresa do in terms of sort of guided imagery experiences to show people, right, how powerful the imagination is. And yes, indeed, right, you can have this powerful lived-in experience that's created by nothing but immersion in the imagination. There's one other model that I want to bring up, which is fascinating. Sofer Dudek was originally a sleep researcher, and there's a suggestion that disturbed sleep disruption, sleep deprivation, all right, makes one more prone to sort of mixed state experiences. All right, that's this, when you've been sleepy, and we all have this sort of hypnagogic experience, so if you're sort of nodding off, where you get these sort of vivid, sort of dreamlike experiences, but they really aren't dreams. And so there's a really interesting question about whether or not sleep disturbances make some people more prone to imaginal absorption, inferential confusion, getting either entering the bubble or getting lost in the bubble. It's an interesting question, and that the suggestion is that maybe attending to sleep issues, sleep hygiene issues, maybe even CBTI, can have a profound influence on these patients. So treatment implications is to just sort of notice that patient, again, the data is clear that high dissociation individuals, this state, this proneness to get lost in the imagination, to experience depersonalization, derealization, that these patients tend to gain less from ordinary treatment, right? There's also the suggestion, and some of us have experienced this. I know that I found this sort of personally useful when I really notice that I am gone in the bubble, which doesn't happen too much anymore, but that might benefit from grounding techniques that are usually associated with treating dissociation within the context of trauma, to focus attention outward and ground the sense of bodily self when getting caught up in obsessions. I know that Margaret, you've talked about particularly working with kids who are really, when they're really, really immersed, that the first thing that you have to do with before you can do any cognitive work is to sort of bring them back into the room, to sort of get them grounded, right? Connect to me, 5, 4, 3, 2, 1. What do you see? What do you hear? Et cetera. This, even Russ Harris's dropping anchor, so that there can be sort of a role for this that you might need to do right, before you can do the cognitive work, right? There also is a suggestion that attention training techniques, right, particularly being able to sort of recognize where attention goes, particularly inwardly focused, and to be more flexible, to have to actually widen one's awareness, one's attention away from this tendency to get fixated on a particular stimulus or a particular story or image, can be useful. Again, this idea about sort of enhancing sleep quality, and then there's a suggestion that we screen for maladaptive daydreaming, in which the individual regularly seeks out absorptive states and is actually training their mind on a regular basis to sort of leave reality and get lost in the imagination. I want to finish with this poem, which is with some of you. It's been a while since this was posted. I think this might have been Laurie Aiken's patient. I can't remember, but I think this sort of captures. This isn't explicitly about I-CBT, but this was brought to Laurie or whoever it was, whoever the clinician was, by a patient who benefited tremendously from I-CBT. I want to finish with this poem. And this guy, Jim Peterson, I tried to track him down. I've contacted a bunch of poets named Jim Peterson, and none of them said that they wrote this poem. So I don't know whether this guy has OCD or not, but I'll read the poem. I know the many doubts that spring from unknown places. They are thoughts without meaning except that which I offer. I've come to recognize this inner voice. It is not my voice. It is a part of me, but only as a dream is of the dreamer. It is a voice that tells me of past hurts and future fears. Is it a voice that only lives in the dream? It fears awakening and its destruction, so it masquerades as me. I am fooled no longer. I choose awakening. And I think that this is the promise of I-CBT. So I'll stop there, and questions, comments. I don't know if Fred's here.
I just want to say that I've heard you talk about imaginal absorption so many times. I really didn't think I had too terribly much more to learn, and you blew me away today. And if you look at the comments in the chat, I think you blew everybody away. This is going to be one of the 4-star, 5-star videos on I-CBT. It was excellent.
Thank you.
Yeah.
Okay.
Thanks, Carl. Yeah, great presentation. Yes, I think the thing about the OCD bubble and dissociation, sort of what everything in I-CBT that we do leads up to, right? It's the culmination in a way. It's where we hope that clients come to a realization that the doubt is false and that it's unnecessary, and that it sounds very simple, like it's all I'm making this shit up, as you say. It's all in my imagination. Sounds like a simple realization, but it's not. It's not, right? And that's why there's so much cognitive work ahead as well that goes before that. But the realization itself is tremendously simple and complex at the same time for that reason. It's a little bit of a paradox. And I think getting people to that insight is profound. It's profound. And that's also what we see, where OCD is not just a continuum where slowly through habit or through learning you change the intensity of obsessions. No, it can be sudden. It can be very fast. And that's what this is about. You're either in the bubble or you're not. Right? So it's in that sense, we're not dealing with a continuity. We're dealing with a either in or out. And once you're out, there's no OCD. And how do you get there? Imaginal absorption is sort of like a continuous concept where you're like more or less absorbed into something, and that's very important. And people differ in that. And like we say in the manual, which you quoted, it is something that probably aggravates symptoms of OCD a lot. But I think the important question to ask as well, and we talked about that in terms of the relationship with inferential confusion, is what makes us get absorbed into something to start with. And that is when we consider a particular doubt or idea to be relevant to the here and now. And when do we consider a doubt to be relevant to the here and now, according to I-CBT, is when we start confusing what are really just abstract possibilities with real probabilities that are relevant to the here and now. Then automatically we get absorbed. Anything that we consider relevant, and like many examples we give, right, in a therapy, like the ceiling coming down without any evidence, if we consider it, if we tell ourselves it's relevant, we have this confusion, inferential confusion between reality and possibility. The absorption is intense, immediate, and it's complete. The problem is that it's unnecessary, So I think that's a little bit how, like you said, the bidirectional relationship between absorption and inferential confusion works on a technical level, from how cognition automatically is tied up with absorption and leads to the lift in character of OCD, where we're living it as a reality, even though we don't have to. Anyways, I just wanted to say, great, also with a lot of experiential living and explanation that you explain it, and I think that's also helps a lot of people understand it, and that you've lived this, and therefore also know what it feels like to either be in the bubble or outside of the bubble. So I think that came across very well.
Thank you. I want to jump in here and say, I think this is where the movie metaphor, watching a movie metaphor, is particularly useful. Early psychoeducational piece, right? Which is watching a scary movie. In this particular case, what you're doing is that you are immersed in someone else's imagination, right? Right. And that when the guy with the chainsaw revs it up, you will feel your palms will get sweaty. You'll get an urge to duck under the seat or run out of the theater. You'll feel afraid, even terrified. And then when you realize it's just a movie, that realization that it's just a movie, right? And how we get to the realization that it's just a movie. Once you do that, there's nothing else to do, right? There's nothing else to do. I mean, is it still possible that you could get attacked by a guy with a chainsaw? Sure, but that's irrelevant. It's it's just silly, right? Right. But there's sort of fundamentally nothing to do, and I think that sometimes can sort of capture part of what we're aiming for, and that the power of that everybody experiences. It's a common experience of what it's like to get lost. And then to extend the metaphor, what we're doing in I-CBT is that we are approaching, is that we want to come to the movie as if we are a script writer or a director. So rather than getting lost in the story, we're going to look at the techniques that the cinematographer, and the director, and the screenwriter use in order to trick the audience, absorb the audience, get the audience caught up in the story, right? And that's a metaphor for how I-CBT can be so helpful. Oh, I see how they do that. Oh, isn't that interesting, that angle that they chose? Or the music that was used to sort of capture the sense, the tension, etc. Right? And when you do that, when you have that perspective, there's no anxiety to tolerate. There's no uncertainty to tolerate. There's no compulsion to do. There's no avoidance. It's just pixels hitting a screen. It's maybe it's an interesting story to be amused by, but that's about it.
Oh, I'm just thinking it would be really cool if somebody, maybe in this group, would be interested in putting together a document with all of our metaphors that have been created around I-CBT so that we can remember them and pull from them when we need to use them in therapy, kind of like the ACT book of metaphors, right? Wouldn't that be cool? So maybe somebody will say, oh, I would like to do that. I don't know, but it's 2:01. We need to wrap up. There were a few questions in the chat. We'll make sure you get those in case you want to answer them personally if there's not time. But I could see us doing a part 2 on this. Honestly, there's so many things I want to say and discuss. I see Susan. They're like, yeah. I'm sure lots of people have thoughts and ideas they want to share and questions they want to ask. But I just want to thank you. This was an amazing presentation. It really, really spoke to me.
Thank you.
You guys have a good weekend.